Welcome to the Action Awards Cycle 2 Final Report presentation for the project led by Dr. Marcia Mecca of the VA Connecticut and Yale University. Dr. Mecca's project is one of 9 that received an Action Awards Cycle 2 grant. The grant period ran from January 1st, 2015 to December 31st, 2015. The Action Awards are a one-year grant for up to $10,000 available to interprofessional teams led by alumni of the John A. Hartford Foundation. The purpose of these grants is to achieve meaningful change to practice or policy by the end of the one-year grant period that will improve the health and well-being of older adults and or their families. We are now ready to learn more about Dr. Mecca's project. Following the presentation, we will engage in a Q&A. Dr. Mecca, can you please begin?
Sure. I wanted to start by saying a big thank you to the Hartford Foundation for the support, and also to our team here, the SPRING team, the screening program to identify needs due to geriatric syndromes in homeless veterans. We are a collaboration between geriatrics, psychiatry, the homeless team at the VA in Connecticut, and a nurse practitioner from our geriatric consult service, as well as some medical students and residents that were interested in working on the project. Next slide. The goal of our project is to screen veterans seeking care at the Healthcare for Homeless Veterans Clinic for geriatric syndromes, cognitive impairment, functional impairment, and frailty. We aim to identify those impairments and then refer veterans with positive screenings to the appropriate resources to help them have success in the housing program as part of the VA services. Next slide. And the stakeholders for our project are the homeless team, the veterans that are a part of the homeless healthcare program, a cognitive subspecialist, and then the leadership of the VA as well, for whom the value proposition is for the project is to identify needs that are geriatric in nature, cognitive impairments, functional impairments among homeless veterans, and then link them to the appropriate resources so that they can succeed in both their medical treatment and in housing efforts that are part of VA services. Next slide. So our main results are shown here. We see that our population of homeless veterans are a little bit younger than you might expect, but that their cognitive impairment and functional impairment rates were higher than you might expect in non-homeless populations. So 70% of the veterans that we screened had an abnormal MoCA score, which is a screening for cognitive impairment. We had all of the patients that we screened were engaged with primary care. 100% had visits in the past year, but not very many of them, 13%, had seen a cognitive subspecialist. Many had seen a mental health care provider. We also had patients with diagnoses of mood disorders, anxiety disorders, and some substance abuse disorders as well. But the impact of our screenings for cognitive impairment is that we identified 70% of patients with cognitive impairment. And we also saw from our screenings, which involved both cognitive screenings and functional screenings, including direct assessments of functioning as well, we found that the direct assessment of functioning correlated best with the cognitive scores than as compared to the brief instrumental functional scale, which only was a self-reported scale. So doing the direct assessment of functioning and cognitive screening really helped us to identify impairments that we could refer patients to the appropriate resources for. Next slide. So our project, so during the Action Award Project timeframe, we saw 57 patients we interacted with about 50 healthcare professionals, and we had a growth in our core team as well, with the addition of 2 medical students and a resident who are interested in working on the project as well. Next slide. So the benefits for the older adults that we screened were the identifying conditions, cognitive disorders that were present, and identifying supportive services that could be helpful. We helped the homeless team support families who were dealing with difficult care and housing needs for older veterans. And we've had some interest about our project for other organizations as well. Primary care providers within the homeless services and other providers within the homeless services have started to consult us as well. So they've recognized that our services were helpful. Next slide. So the lessons we've learned are that cognitive and functional disorders are common among veterans who are homeless or who are at risk for homelessness. The challenges that we found are actually during the course of our project, there was some press about the end to chronic veteran homelessness. And so we had the challenge of that good press, but also to identify that there's also acute episodes of homelessness and that chronic homelessness has a specific definition, and that we still have an important role, that there are still homeless veterans who need help, and that our intervention is an innovative way to help those folks. And our successes were, initially we were concerned that when we referred patients to additional resources that they might not attend those additional referrals, or that veterans might not want to participate in our screenings and that sort of thing. But we've really seen that that wasn't the case, and that the program has grown as well. So those are our successes. Next slide. So our next steps with the project are to gather long-term follow-up data at 6 and 12 months from the screenings to identify the impact on housing outcomes for veterans, and also to look at all the components of our screening program to identify those areas that were most predictive of difficulty with housing and those areas where interventions made the most difference for housing outcomes, to sort of streamline the process that we are doing now to move things forward. And we are also looking to see how our findings will compare to a control group of veterans, a comparison group to those veterans who have housing instability as compared to those who do not. And then we are also working forward to get additional support for a staff member to continue these screenings long-term, and also to publicize our findings in a variety of ways. Next slide. We have presented posters at AAGP, AGS, and SGIM, and again are looking at the more long-term findings of our project as well. Next slide. So in conclusion, we've been able to identify geriatric syndromes among homeless veterans at earlier ages than we were expecting to find, but we have also been able to identify resources that could be helpful for them to meet those needs. So we're identifying undiagnosed geriatric syndromes and matching the appropriate resources to folks to improve their success in the housing program. Next slide. I think that's it.
Wonderful. Thank you so much, Dr. Mecca. What a excellent project, such an important project. And we just had some questions I'd like to share with you. And the first is, through your findings, you've shown the multiple needs of these homeless individuals in the VA system. And we wanted to pick up on thinking about your next steps. Your goals were to perform this screening and then link those needs identified in the screening to existing resources. And in thinking about ways of moving your project forward, or thinking about other VA systems who may be interested in other VA systems adopting your process, the question is whether or not there was resistance in terms of staff buy-in to adding the screening process into care, and whether that was a factor that slowed you down.
I think the project has definitely evolved over time, and at first there was some difficulty with identifying, exactly what we were trying to do and why. And what happened over time was that the providers recognized that the evaluations and referrals that we were doing were helpful to their veterans. And actually over time now we've been getting consults from them, asking for our additional help. So I think that as the project has moved along, then there's been just sort of naturally more support and understanding and appreciation and requests for help.
Mm-hmm. That's great. Oh, good. And so we're also wondering, have you worked with any veteran groups or veteran advocates, and were they supportive or did they push back at all on this approach that you took?
We really engaged veterans from the beginning. So as we were first setting up the screening clinic, we really worked with the veteran to see what worked, what didn't work, and to try to streamline the process and the exact order of things and how to set it up. We really did work with the veterans initially when we were first setting up the screening to make sure that that we were meeting their needs as well.
Oh, good. Yeah, very important stakeholder group. I want to go back to your learning section. Let me see if I can bring that up quickly. Here we go, learnings. So under successes, and you talk about the rate of referral of appointments. And we were trying to wonder if you were able to tie that process measure, the rate of referral of appointments, to an outcome or an outcome measure. I was just trying to link up the actual rate of getting supports as well. They were showing up to appointments, but how often were you able to fulfill those needs with services?
Right, I think that's important as well because it's more than just referring them to the services, making sure that they get that service and that it's effective. And initially we were concerned, we weren't sure whether veterans who were referred would have difficulty with transportation or difficulty showing up for these follow-up appointments, but they really did. We really didn't see that as a problem. They were able to make and keep these appointments well. It was an initial concern, but we really found that was not a problem.
Mm-hmm. Okay, and then what about kind of a follow-up, linking them to service, but there's, been the barriers in the VA systems that perhaps interfered with them connecting with the services in a timely manner, and whether this was the case or you anticipated this the case, just all the media coverage that had been around that and surrounds about veterans getting services, did that become an issue for you at all during this project?
So access problems at our VA in Connecticut have really not been a problem. So we have found that our project at VA Connecticut has really just increased awareness of geriatric syndromes and increased the referrals of patients to the appropriate resources, but there hasn't been a problem in getting people into those resources. It's more an awareness of an identification of the problem and then the appropriate referrals to help with that difficulty. So access has not been a problem for our project.
Oh, that's good. And so then media was not really on this at all. Like there was no implications from the various media coverage because of it wasn't related to your specific DA, I guess.
Correct.
Okay, great. And then we're wondering, how can your screening, your project, become part of the Veterans Administration approach, and how could it be integrated in service provisions overall for veterans?
Well, the VA is very data-driven, and so I think that this project has really been helpful in collecting the data about how an intervention like ours could be helpful for veterans in a variety of different outcomes, including access to care, access to appropriate care, and that sort of thing. So what we're hoping and what we're so thankful for is the Hartford's funding to support that, because we have been able to identify how such a program would impact veterans, and there are homeless services clinics, all over the country, and so we can demonstrate that these interventions have really made an impact. I think moving forward, it may be something that can be implemented in other VA homeless clinics as a sort of different way of approaching, not really a different way of approaching, but a complementary way of approaching homelessness among veterans.
Right. That's great. Okay, shifting gears just a little, given the frailty, the cognitive and physical and the functional issues that you uncovered, have you involved any occupational therapists and physical therapists as part of the team?
Absolutely, and that's one of the things we have found is that there are a variety of, every veteran is different, so there's a variety of different resources that might be needed for a particular veteran. And so we have definitely referred patients to occupational therapy, physical therapy, to cognitive subspecialists, be that geriatric medicine, geriatric psychiatry, neurology, and really, just trying to identify areas of need, a visiting nurse, and those sorts of things. So whatever difficulties we identified in our screenings, we really tried to identify something that could be helpful to the veteran for that problem, and made those recommendations and referrals.
Good. That's great to hear. And just a final kind of feedback that was provided that I wanted to share and get your feelings on it. The person understands your need, the need to move forward to try to fund a staff person to do the screenings, but it also made him think that as an alternative, you may want to think about if there are other things that are less important that the staff currently does, or if this is something that you can weave into something a staff person is already doing. Is that something that would be a possibility, or does it have to be a separate staff person?
I think that's a great question, and I think that as we identify those components of the screenings that are most vital and most helpful, and then some sort of guides to how you match these impairments or difficulties with particular resources, I think that it could be incorporated into the general screening process that happens in the Healthcare for Homeless Veterans Clinic, and that it could be incorporated in that way, or perhaps a shared position that it could be streamlined into the process overall with the evidence that this project provides to its benefit.
Right. Oh, good. I'm glad you're thinking about that too. Well, those are all of our questions, and we've come to time. And I just want to say thank you again, Dr. Mecca, for just your excellent presentation and for just all the hard work that you and your team are doing, have done, and I know that you're continuing to do. And we really appreciate you being here. Thank you.
Well, thank you. Thank you very much.
You're welcome.